Okay, well, hello, welcome everyone to the sixth and final part of our Global Antimicrobial Resistance webinar series. And today's webinar is entitled Evaluating an Antimicrobial Stewardship Programme, What are the Measures of Success? I'm Angharad Davis. I'm a consultant medical microbiologist and clinical director for publishing and engagement at the Royal College of Pathologists. I've had the great pleasure and privilege of chairing this series of webinars. Before we get into our presentations, I'm going to provide a quick overview of the series because it's still available as recordings online. So these are the topics that we've covered in our six-part series. We've delivered a webinar a week on the topics that you can see and involving speakers from countries around the world, like as you can see in the column on the right there, a number of different countries represented. So all of those webinars will be available as recordings online. So if you've missed one and you'd like to watch it, then you will be able to find it on the RCPath website. So here's the agenda for today's webinar. We will have the topic introduction and the UK perspective, followed by perspectives from Canada, Egypt, and Hong Kong. Afterwards, we'll have our Q&A session. If you have any questions throughout the webinar, please enter them into the Q&A box and we will aim to answer them at the end of the session. We won't take questions in between each speaker, we'll take them all at the end. But please feel free to enter the questions whenever you like as we go along, and they will stay there safely until the end of the session. So to provide our topic introduction and the UK perspective on this, we are very lucky to be joined by Dr. David Jenkins. Dr. Jenkins qualified from King's College Hospital Medical School and has been a consultant medical microbiology at the University Hospitals of Leicester since 1997. He served on a number of national bodies, including the Council of the Royal College of Pathologists, the Healthcare Infection Society, and the Central Sterilising Club. He's the immediate past president of the British Society for Antimicrobial Chemotherapy, or BSAC, which I'm sure many of you are familiar with, and an elected member of the Executive Committee of the International Society of Antimicrobial Chemotherapy. As part of his BSAC presidency, he instigated and led the development of the Global Antimicrobial Stewardship Accreditation Scheme, known as GAMSAS, which is a quality improvement initiative aimed at tackling antimicrobial resistance. And his research includes behavioural aspects of antibacterial prescribing. So, David, thank you so much for joining us, and we're looking forward very much to hearing your presentation.
Well, thank you very much, Angharad. And I just need to share the screen. I think you've got to stop screen sharing, and then I can now share. And hopefully that is the right screen. And let me know if you can't see my slide.
Can't see the slides yet, I'm afraid.
You can't? Yeah, got to press that button now. Yeah. Does that work?
Oh, they're coming now. Yes, we can see them now. Perfect. Thank you.
Excellent. Thank you very much. Well, as I say, thank you very much, Angharad, and to the college for asking me to present and giving me the opportunity to talk about this. It's a subject matter which I've spent a bit of time on over the last few years, and I think it's a really important piece of work. And I'm really happy that the college has done so much on this through these webinar series. I'm David Jenkins, a medical microbiology consultant in Leicester, which for people outside the UK is right slap in the middle of England. And just to let you know that, as Angharad said, I have been the president of the British Society for Antimicrobial Chemotherapy. And so that's obviously important, I think, in terms of the work that I've been doing. It'll be important in the presentation, as you'll see towards the end. So let's start off with definitions of antimicrobial stewardship, because I think this is one of these terms that gets bandied around a lot, and it's not always interpreted by people in the same way. People have different understandings of what stewardship means and how it should be implemented. And to some extent, that diversity is absolutely fine because we all work in different settings. But there should be some overall general understanding or agreement of stewardship. Just to kind of make the point about difficulty understanding it. I mean, antimicrobial stewardship is a very English language word. And a very nice review talked about the difficulty of translating that into different languages, and causing difficulty in classifying what stewardship is and is not, and consequently what stewardship practitioners should be doing and how they should be communicating their roles to other people. But there have been a number of definitions, and one definition is stewardship is defined as an organizational or healthcare system-wide approach to promoting and monitoring judicious use of antimicrobials to preserve their future effectiveness. Another definition is about a functional definition. What is the goal of stewardship? And with this regard, one of the goals of stewardship is to optimize clinical outcomes while minimizing unintended consequences of antimicrobial use. And that obviously includes antimicrobial resistance, but also toxicity and ecological effects such as the selection of pathogenic organisms such as Clostridium difficile. I've tried to put all of this together and create an overall definition which hopefully captures all of these things. And I just want to highlight some important parts of this definition. So first of all, it is an organizational approach. It's not about individual prescribing, although that's very important to the end point of stewardship, but it's primarily an organizational practice, an organizational approach. And it's an approach to improving the quality of antimicrobial prescribing. So that doesn't mean just stopping antibiotic prescribing. And one of the criticisms that's often leveled at stewardship is that it's preserving antibiotics at the expense of patient care. That shouldn't be the case at all. We want good quality antimicrobial prescribing, endeavoring to improve patient outcomes, whilst at the same time minimizing drug adverse effects, antimicrobial resistance, and healthcare costs. And I think these are all very important, and I don't think they're contradictory. I think we can work simultaneously at all of these aims and we get a really good outcome. So here are some references to support all those statements. Well, another thing that often I think there's a misunderstanding, is that people very much focus on the prescription. And obviously the prescription is a central part of this, and knowing which antibiotic to choose, the dose it's given and the frequency and for how long and by which route is really important. But actually there's more to it than that. Before any prescription should be written, there should be some attempt at identifying an infection. Not only, does the patient have an infection? If they do have an infection, where is it? What is it caused by? And getting some kind of understanding of what that infection might be due to from a microbiological perspective. So these elements of history, examination, investigations are very classic elements to understanding what's going wrong with a patient, should be addressed and should be part of any stewardship monitoring process. And importantly, of course, is microbiological investigations. And then following the writing of the prescription, you can't just stop at stewardship there. You need to look at what administration elements are there, the accuracy of administration, timeliness, are the drugs being given at appropriate intervals? In many countries, there's always a big question mark about whether this is a good quality medicine or not. Counterfeit antimicrobials are very common in some parts of the world. And that's an important part of stewardship that needs to be included in the antimicrobial stewardship program. And then finally, there's the patient response and microbiology results, and making sure these things work together. So switching antibiotics, focusing in on antibiotic treatment on the basis of microbiological results, but also reviewing clinical progress and either changing antibiotics, stopping antibiotics, switching the route, and so on. So it's much more than just a prescription. I hope I've kind of made that clear. So it's the right drug at the right time, at the right dose, for the right duration, with everything else going on as well. And I wanted to emphasize it's an organizational thing. And this is where stewardship comes in. It's an organizational governance process. So it's more than just the sum of the individual prescribing. It's overseeing the activity of prescribers and how that fits into what's causing infection and the resistance profiles of the organisms that you're dealing with. So that's another important part of it. And then looking at stewardship activities, they can be often categorized into three major groups. Persuasive, so for example, education, leaving reminders on paper charts, if we still have paper charts, getting key opinion leaders to support prescribing, restrictive prescribing based on limiting the antibiotics that are being reported by the microbiology lab to just the key ones that you want to be used, limiting the formulary, limiting access to drugs on the formulary. And then the third major part of stewardship activity is structural. And that includes, for example, I suspect increasingly is going to include AI approaches to supporting good prescribing practice. And finally, don't forget antimicrobial prophylaxis as an important part of stewardship. We've very much focusing on treating patients with active infections, but there's a large amount of antibiotic being prescribed as prophylaxis, and that's really important to get right as well. So we talked a bit about the scope of stewardship. Now I want to break it down into four major elements: governance, education and training, audit and surveillance, and targeted quality improvement interventions. And when we're thinking about these four major elements, we can break these down into three cross-cutting subjects: structure, process, and outcome. And I'm going to talk a bit more in detail about all of these elements over the next few slides. So let's start off with governance. And this is, to my mind, the key that unlocks good stewardship practice. You really do need to make sure that the governance is in place. And what do I mean by governance? Well, first of all, the structure. Do you have senior management engagement? Is your chief executive supportive of antimicrobial stewardship? Is that matched by the lead medical director and chief nursing officer and everybody else? Do they all buy into stewardship? And how is that commitment demonstrated in real terms? Is there adequate funding for the antimicrobial stewardship team? Is it properly resourced in terms of IT support, for example? Then do you have an appropriately constituted stewardship committee with good administrative support? And what I mean by appropriately constituted is having representation from key clinical areas and also management areas, operational, finance, and obviously cleaning and domestic services and estates are really critical to this as well. So having good AMS committee is fundamental. And the point of the committee then is to oversee and to challenge and to hold to account the antimicrobial stewardship team. And that team needs to be made up of relevant membership, and that will change from country to country. In the UK, it's mostly medical microbiologists, antimicrobial pharmacists, infection prevention nurses, and often we don't have enough infection prevention element to the AMS team, but I think it's really critical. But also data analysis. And again, we generally don't have enough data analysis support for our AMS team in the UK, and I think that's something where we do need to improve. And then you also need antimicrobial stewardship leads in clinical areas, and that could be at a kind of high level, such as a clinical management group, or down to ward level. Do you have antimicrobial stewardship leads on your wards? And I was visiting a hospital in the Republic of Ireland a year back, where they have, in addition to their sepsis nurses and infection prevention nurses, those lead nurses, those link nurses also carry out a stewardship link service. And that was really impressive in terms of making stewardship an everyday event for everybody on the wards, including the nursing staff as well. So I think that's a really great thing to have. But getting that structure right is really important. And then obviously that structure needs to be doing things, and that's the process. So does the committee meet regularly? Is there good attendance? Do they go through all the relevant matters? Have a look at the minutes, review your minutes. Do you have an annual plan that sets out what you want to do over the coming 12 months in terms of antimicrobial stewardship objectives? Have you allocated actions to the appropriate people? And then after a year, you want to be able to have an annual report to say, this is what we set out to do. This is what we've done. These are other things that have come along. What are our successes? What were our successes? What were our failures? What we're going to do about all of those? And again, looking at outcome, then, do you have the governance structure? Do you have the governance processes, such as policies and prescribing guidelines, in place? Do you have an education and training program set up? What about audit and quality and surveillance and quality improvement interventions? Now, these things lead into the next bits. So, for example, the next bit, education and training, and the structure here then is having resources available for the production of educational resources. So are the people in your organization who are specialized in developing educational resources? Make sure they're part of the stewardship process. And make sure that stewardship is embedded in your organization's education and training program. It shouldn't be a standalone. It should be seen as an inherent embedded part of your hospital's quality delivery. Make sure that you have the resources available and that they're developed for everybody involved in the stewardship program. That's obviously prescribers, but it's also nurses as well. Thinking back to that prescribing pathway, who are the people who most often identify that the patients have infections? Certainly in my hospital, it's nurses. They will see an inflamed surgical wound. They'll hear a patient coughing. The patient will complain to them about diarrhea or urinary tract symptoms. So making sure nurses are heavily involved in stewardship is really fundamentally important. Of course, pharmacists are central to stewardship practice as well. But don't forget about the role of management and the board. You need to be feeding back to your management and telling them what you're doing, what are the problems, what resources you need, and what are the consequences of not getting those resources. So that's an important part of the education and training process. And then demonstrating that you've got attendance at educational training resources, that people have undertaken the training, but more importantly than that, that they're actually implementing that understanding into real life practice. So some really important parts there, I think. And this, of course, then leads into audit and surveillance. So you've got your antimicrobial stewardship team set up, including hopefully an audit team, audit functions within that team. And as I say, I keep saying data analysis, that's really critically important as well. So at the beginning of the year, you need to set up what sort of audit and surveillance practice you want to do over the next 12 months. Now, I recognize that events interfere with our plans, but nevertheless, if you fail to plan, you plan to fail. So set up an audit and surveillance timetable in your annual program and make sure you've got mechanisms for data collection and analysis established as part of that structure. And then obviously you undertake these audits and surveillance, and you make sure it's not just a matter of doing the surveillance or audits and leaving it that. You've got to then have included in that mechanisms for reporting the results to relevant clinical and managerial groups. Always think, who do I need to tell about these things in order to make a difference? Surveillance is not, audit and surveillance is incomplete until you've fed back to people who can make a difference with the results. And evidence then that those audit and surveillance results are prompting appropriate actions is really critical in terms of understanding that your stewardship program is working. Now, what kind of measures would you want to undertake? Well, I've divided this up into 4 major groups. The first group is patient measures. And I think that's really, what is the point of stewardship? It is to improve patient outcomes. So until you're putting patient outcomes first and foremost amongst all of these things, you're not really doing stewardship appropriately, in my view. So you've got to make sure that patients are receiving appropriate treatment. So we need to be looking at that through audit, through surveillance. We need to be looking at what outcome they get. And that includes things such as cure rates, but also duration of treatment, duration of illness, adverse events such as allergic reactions, Clostridium difficile infections, and so on. And I think a fourth element, which is, I think, poorly developed in at the moment in stewardship practice, is equity of application of stewardship practice. Are we look at your patient groups? Are there some patient groups who really need much more attention than others because, for example, of high resistance rates, or because traditionally they've been undertreated or infections have been under-recognized in this group? So a fourth element there, equity of application of stewardship practice, I think is critically important. What about measuring antimicrobial use? Well, there's some really straightforward measures there, well-established ones, such as defined daily doses per 1,000 bed days as a rate of an antimicrobial use. And this, having a measure such as this, which is allows you to benchmark your performance against other organizations, I think it's a really valuable thing. You need to be looking at using the AWARE classification, IV to oral switch, and antimicrobial resistance measures such as rates of resistance of multi-drug resistant organisms, MRSA, vancomycin resistant. I put vancomycin, that's an error there. It should be ESBLs and CPEs. And finally, something really important we miss out a lot on, look at the costs and administration costs, operational costs of getting it wrong and getting it right. Does stewardship improve the financial situation of an organization? Does it improve the operational flow in terms of reducing length of stay and reducing readmissions? So targeted quality improvements, structures such as protocols in place to prospectively gather and analyze quality indicator data, AMS committees, including quality indicators. So you will find some parts of your care which require additional attention. And again, setting the structure in place to identify those so that you know what's going wrong, and you can identify clinical areas of targeted interventions and then apply those quality improvement interventions, for example, using a plan, do, study, act protocol. Don't forget microbiology laboratory and infection prevention support and components of this. Really, microbiology laboratories are critical to good stewardship practice because you can't really do much unless you know about resistance and the organisms. And infection prevention is really important as well. There was a great meta-analysis carried out in 2017 looking at the impact of stewardship on reducing antimicrobial resistance. And stewardship does reduce resistance, but it does that even more when it's coordinated with good infection prevention practice. So I really recommend having a look at that paper. What about assessing your own program? Well, first step is self-assessment. In the UK, we have the Health and Social Care Act Code of Practice, which sets out a requirement for healthcare organisations to ensure that stewardship is being optimised. Well, one of the things you can do is look at some published quality indicator guidance. And I've given an example here of quality indicators for appropriate antimicrobial therapy in the emergency department. Obviously, don't look at the detail here. Go to that paper and have a look at it. I think it's really important. But there are many other quality indicators that are worth looking at as well, which will be cited in that particular paper. Then the next thing to do is do peer review. Find an organization that looks similar to you, got a similar case mix. Agree with them on what you want to be looking at and any quality indicators that you've developed and want to be reviewed, and then arrange for reciprocal review. So you go and see their stewardship practice, they come to see yours. You both get a fresh pair of eyes, and it's really, I think, very valuable to give you insights into how stewardship can be done differently, and it benefits both the assessed and the assessor. And then finally, assessing your own stewardship program. Get an external review and get an accreditation. Now, BSAC have set up the Global Antimicrobial Stewardship Accreditation Scheme. There's the link there for you to see. And what we do with our accreditation program is review quality on 4 principal components based on published standards. The reviews are conducted by independent professional peers, and its aim is to encourage organizational development. So it's not just ticking a box, everybody going back to standard practice the next day. Once you become part of the accreditation, the GAMSAS accreditation program, it's a continuing quality improvement program. We provide support and networking. And the GAMSAS program has been recognised by the recently published United Kingdom Government Antimicrobial Resistance National Action Plan, and it's figures in there, and you can again go and look at that on the National Action Plan website. So there's some really useful resources from the British Society for Antimicrobial Chemotherapy and the International Society of Antimicrobial Chemotherapy. These are free online resources. I think they're really valuable. If you're not a member of BSAC, then please consider joining. It's free membership. Just go to the BSAC website. And in summary, I think regular evaluation of an AMS program is vital to ensuring its continuing effectiveness. It's very easy to sit on your laurels, but you will be left behind and things will get worse. You need to be continually reviewing and improving your AMS program. That starts with an internal review based on the elements I've just discussed. But even better then is getting an external review, including peer review, but also accreditation. And if you do all that properly, then you will go from strength to strength, and your patients will benefit, and your antimicrobial resistance problems will be tackled effectively, because it's not something that would be sorted and finished with once and for all. It's a continuing challenge. The changing nature of microbiology and resistance in clinical practice means that no AMS program is ever complete. We can always learn from each other, and sharing is the best thing we can do. So thank you very much for your attention, and hopefully there'll be time for some questions at the end.
Thank you very much, David, for that really excellent comprehensive presentation, which I found really, really interesting. Thank you very much. Please, if you have questions for Dr. Jenkins, please put them in the Q&A box and we'll come to them at the end of the session after we've heard from our other international speakers. So thank you, David, for now. And we're going to move on next to hear the Canadian perspective from Dr. Daniel Thirion. Dr. Thirion earned his Doctor of Pharmacy degree from the College of Pharmacy at Wayne State University, Detroit, Michigan. He's currently full clinical professor of pharmacy at the University of Montreal, where his teaching responsibilities are focused on infectious diseases pharmacotherapy. He's founded and developed the Antimicrobial Stewardship program at the McGill University Health Centre, which is recognised as an exemplary practice by Accreditation Canada. His contributions have included development of research in antimicrobial stewardship and prophylaxis in surgery. So thank you very much for joining us from Canada, Dr. Thirion, where I know it's very early, so we really are very grateful to you for joining us. Thank you.
Yes, it's my pleasure. Thank you for this opportunity. I'm unable to start my video, but I'll start sharing the screen here for the slides. Okay. So thank you for giving me this chance to be able to present to you what our current practice is in Canada. And just to give you a perspective, we have about 200 hospitals that are covering about 30 million people across Canada. Now we have a process in Canada, it's called Accreditation Canada, that accredits and establishes the standards for evaluating hospital care. In this, we have one process that is required, which is called the Antimicrobial Stewardship. It's under the Medication Management Program. In this, there's established criteria for hospitals to meet this standard. And I just want to give you an idea of the perspective of what the hospitals are going through. And actually, the criteria to be able to meet an accreditation level would be to have an antimicrobial stewardship that has been implemented. Actually, this is just having it recognized by the administration. There should be a string of accountability. That means that the person who's leading the program has to be able to report on a regular basis with our administration. And they have adequate resources that are allocated to the program. And this includes a multidisciplinary team of physicians, pharmacists, infection control specialists, microbiology staff, nursing staff in hospital administration, and information systems specialists when they're available and appropriate. And finally, there's a fourth criteria, which is to have interventions that optimize antimicrobial use. And actually, the current criteria that have been established for about 10 years are somewhat loose because they're not prescribing a specific intervention that has to be done and having specific measures to be able to report. And so depending on the hospital resources, there's a lot of flexibility allowing the hospitals to adjust to what their needs are. And then there's minor criteria actually that the program is being evaluated on an ongoing basis and for which the results are shared with the stakeholder organizations. So the criteria actually are at this point are going to have to be updated. Some hospitals are just managing barely to meet this criteria, but our major institutions with intensive care or transplant units are far beyond what's being presented as a required process. And so the question that I've been asked to is to look at how do we measure our antimicrobial stewardship programs in Canada. And I'm providing here just a brief summary of how we approach this. We have different areas of measurement and different methodologies. So when I'm talking about applications, there's a whole bunch of different methodologies to be able to measure those. And actually these different methodologies lead to different outcomes or a different type of impact. So we really have to select what you want to do. And again, our accreditation levels in Canada do not prescribe any of these on a specific basis. So our antimicrobial stewardship personnel are free to choose whatever they want to be able to start reporting what they want to do with their physicians and pharmacists and nurses within the wards, and however they want to do it with their administrators. So just briefly, and I'm just providing you with my personal opinion, but you should be able to do some basic antimicrobial use metrics, and these are actually important if you're trying to identify opportunities where you want to intervene within your institutions. And then you can move down however you feel like targeting your stewardship program. And I just want to mention that usually stewardship programs are targeted according to 3 levels, either a ward-based intervention, a prescriber or team-based intervention. So if you're targeting an internal medicine unit, transplant unit, intensive care unit, the emergency room, or again, you can target your interventions according to specific disease states, or for pneumonia, hospital-acquired, community-acquired, urinary tract infections. It can be prophylaxis. So you really have to figure out how you want to measure the way you're designing your own program. And then you can move on to outcome measures, process measures, prescriber measures. These 3 types of events will provide different impact on what you're doing. So outcome measures actually, I think, are one of the most important aspects of trying to measure the pertinence of your program. However, these are actually the most difficult to measure because you have to have extensive data management, and that can provide you with quick results. Doing this by hand is impossible. Process measures will be able to measure specifically what is the impact of an antimicrobial stewardship program. Because you are measuring exactly what you are intervening on, and you are able to report what is a performance on that targeted goal. And when we're looking at prescriber measures, actually we use this as behavioral changes. These are mostly used as report cards, and you've probably realized that the best tool you may have under behavioral change is actually using competition. We've noticed that our physicians are highly competitive among their own teams. And so just reporting keeping the data anonymous, but just reporting their own performance compared to their peers actually gives them a fair incentive on how to improve their care. And then, as mentioned earlier, we have some quality and safety measures that can also include patient-oriented measures that they would prefer. And finally, we have the financial metrics, which there's a ton of ways of measuring this, but are actually extremely important with your administration to be able to document how you want to look at your programs to get human resources. I'm just going to go briefly over the different measures that we have. And actually, I'm just showing you the formulas for the basic antimicrobial use metrics. These are actually minimum standards. And so this is why I'm presenting them. The ones that we're seeing a lot used in the European system are the defined daily doses. Why are we using DDDs in Europe is because they're easily accessible. The pharmacy computer systems are not necessarily permissive to do any other type of measure. And there's a lot of specific limitations that you have to understand to be able to use the DDDs appropriately. But this type of measure has been used for almost 2 decades now, and is actually fairly accepted as an appropriate measure for basic antimicrobial use metrics. If you look in North America and mostly in the US, the measure that's being used is mostly days of therapy. And days of therapy actually requires strong informatic systems process that measures all the data that you require to be able to measure this correctly. There's a lot of specific definitions that you have to respect to be able to measure days of therapy, and not all systems are up to speed to be able to use this. Now, there's different denominators that are being used, either patient days, admissions, and discharges. These are just a couple of examples. Mostly patient days are the ones that are accepted. You can measure those according to each institution. You should be able to get that kind of data because they are also used for other indicators within the administration for your hospitals. But there are also other metrics that we use at the national and international levels. For example, the amount of antibiotic use in the communities per inhabitants, and those are used on different perspectives of antimicrobial stewardship in the different types of nations. Now I'm going to dive into what the Canadian setting is providing. And so we have Health Canada that supervises or oversees or tries to organize antimicrobial use metrics. And we have been sort of limited with the amount of infrastructure that's available from the computer side. And so this is why we have some basic antimicrobial use measurements that have been available since 2009. And we have been presenting this and publishing all our data for the past decade. So this is just an example. And maybe if you want to know what's going on in Canada, is that you can see that the major target of our antimicrobial stewardship programs have been the fluoroquinolones, for which there has been a constant decrease in use in favor of more narrow spectrum or safer antimicrobials, including the penicillins and cephalosporins. Health Canada has recently put up a website, and you can access this data if you're ever interested in comparing your own performance to a country's perspective. And here we have a longitudinal presentation of antimicrobial use per class per year, for which you can follow the trending events. And again, this reflects, for example, the use of fluoroquinolones that have been decreasing while in the favor of other antimicrobial classes. One aspect, depending on the strength of your computer systems, is you want to be able to narrow down or focus on specific wards and specific antimicrobials of interest, depending on your antimicrobial resistance rates and depending on your patient outcomes. And so here we're presenting again some data that's available on a Canadian website from Health Canada, on which we're able to focus on ICU wards and non-ICU wards for specific antimicrobials of choice. And this allows our different hospitals to benchmark themselves and identify opportunities. And again, we're using the classification as mentioned earlier on access, watch, and reserve antimicrobials that may be of interest. And of course, for us in Canada, our specific interest is mostly on the carbapenems. And here you can measure the meropenem use that we're seeing in our ICUs across our different institutions and compare that to our non-ICUs. I'm also providing different work that has been done by some of our researchers. And so here we see that the measurement of antimicrobial stewardship is actually evolving quite quickly. So in 2019, we published a paper looking at point prevalence, the correlation between point prevalence measures and defined daily doses. The defined daily doses is providing measurement over time on a continuous basis, and is actually easier to get this type of macro data. However, it doesn't provide you good information on specifics. One of the most difficult metrics to get is the indication of antibiotic use. And getting into indication of antibiotic use provides more specific information if you want to intervene on specific disease states. And so we've noticed that using point prevalence technology methodology is actually acceptable and reflects what is the overall use of antimicrobial use throughout time. And in Europe, there's a group coming out that have developed a project that's called the Global Point Prevalence System. And this has been used across the planet. They've been publishing like crazy throughout all the infectious disease papers and journals. Here we're presenting our Canadian data that was just came out a few years ago, but shows you the type and class of antimicrobials that are being used per indication. And this is actually quite insightful because you're able to identify opportunities for intervention for specific disease states. And it gives you a better insight than the macro data that you're seeing through defined daily doses. And so I just wanted to focus on a few things. This is how we've classified some of our data looking at specific indications. We can look into our community-acquired infections, our nosocomial infections, and looking how we're using some of our antimicrobials. And this is just an example. We're looking, for example, in this case, at the right end of the graph, at the use of antimicrobials in urinary tract infections, either lower and upper urinary tract infections for community-acquired infections. And we noticed that there's still an 18%, about a 15% use of broad-spectrum antibiotics. Here we're talking about piperacillin tazobactam for lower urinary tract infection acquired in the community. And so at this point, we can see that there's some inappropriate use of some of the antibiotics, and this can be done actually with quite quickly. So what we're talking about is doing a point prevalence, a one-day survey of your antimicrobial use, and it allows you to identify opportunities for stewardship. Moving on to other measures and metrics. So depending on what you have access as data, you may want to measure some specific outcomes. This is actually more difficult and out of reach of our usual hospitals, and it's mostly done through research through our large institutions. But in this case, we've had a couple of initiatives that have been looking at the C. difficile infection rates according to antimicrobial use, trying to establish if there's a relationship between our stewardship programs and its impact on C. diff. The second section I'm just showing you below is one of our infectious disease physicians noticed that when they're doing some specific clinical trials, they've noticed uptick of off-label study drug in non-study setting. So actually, if we're doing, in this case, it was a daptomycin trial that they were doing in bacteremia, and they noticed that the physicians were copying them on other wards and using daptomycin for other indications that we're not supposed to. And finally, I think this is one of the key interventions that we have done in the early implementation of our stewardship programs, is that we addressed our antimicrobial prophylaxis in surgery, and actually we targeted 9 surgical specialties. This was actually a pretty huge endeavor. And I don't want to go through all the data, but what we've demonstrated in this case is that we had a 50% drop of surgical site infections due to improvement in our antimicrobial prophylaxis use. And this is in addition to our other interventions of infection control. And this 50% decrease in cardiac surgery translated to approximately 50 surgical site infections that were avoided per year in our cardiac surgery unit, which translated to approximately a huge amount of dollars. And the message that we want to understand from this outcome measures is actually this is where you will get the most impact financially from your stewardship program. So it's extremely difficult to measure all of this, but if you're able to demonstrate a definite impact of your stewardship program on a specific outcome, those patient outcomes are what cost the most and where you get the most savings and how you can justify your program. So in this case, we were mentioning that we would save maybe 100,000 euros per year because of our antibiotic stewardship program, but this would justify just barely sufficient resources for one person. But if we look at our outcomes, we were saving about 5 million euros per year, and this was easily justifying the manpower required to be able to produce this kind of data. So that's the final word I want to present regarding financial metrics. You have a bunch of different types of financial metrics that can be used. And again, your administrators are using a whole bunch of data for their own reports on a whole bunch of different aspects of measuring performance for the hospital. And so those metrics are actually pretty easy to get, but they're maybe less specific. And so what you really want to be able to focus on is on your outcomes to be able to justify the antimicrobial stewardship program. So within the allotted time, I will conclude on this, and I will remain available to answer any of your questions at the end of this panel meeting. Thank you very much.
Wonderful. Thank you very much, Dr. Thirion. Really interesting, with lots of great data there that you have that I'm sure we will want to discuss again later in the Q&A session. So thank you. In the meantime, We're going to move on to hear from Egypt, from Dr. Silvana Garba. Dr. Garba is Assistant Professor of Medical Microbiology and Immunology in the Faculty of Medicine at Fayoum University, Egypt, and Head of the Infection Prevention Control Unit of Surgery in the Fayoum University of Egypt. So thank you very much for joining us. We're looking forward to hearing the Egyptian perspective. Thanks very much.
Thank you, Doctor, for your introducing me. Yes, the objectives are to identify antimicrobial resistance in Fayoum University Hospital, to define the antimicrobial stewardship program, and to describe measures for performance evaluations in form of process indicator and outcome indicators. Fayoum is a city in Upper Egypt located 100 kilometers southwest of Cairo, capital of Egypt. Fayoum University Hospital teaching hospital are composed of 3 hospitals, one for internal medicines and another one for surgery with 600 inpatient bed, and the pediatric hospital also with different specialties. The outpatient clinic serving the Fayoum government and its outskirts more than 2.5 million inhabitants. Regarding antimicrobial resistance, actually in Egypt, the number of deaths from AMR is higher than this from diabetes, kidney disease, chronic respiratory disease, and neurological disorders. At Fayoum Surgical University Hospital, regarding surveillance program data revealed that there was increase in risk of hospital-acquired infections with multi-drug resistance and even extreme drug resistance, especially during COVID period and after COVID era. The most common multi-drug resistance bacteria and even extreme and now maybe banned drug resistance in our hospitals are Klebsiella, Acinetobacter, Candida non-albicans, Pseudomonas, coagulase negative staph, and E. coli. So we were in need of implanting antimicrobial stewardship to reduce resistance, to reduce hospital-acquired infection, to optimize antibiotic prescription, and to improve patient outcomes. So programs need team and a strategy. Actually, at Fayoum University Hospitals, we have antimicrobial management team, include microbiologists, clinical pharmacists, infection control practitioner, clinicians, nurse, and infection and information technology. The antimicrobial team prepared the antibiotic policy for the hospitals since 2022. Also, regarding hospitals of Ministry of Health, Egyptian drug authorities in Egypt form antimicrobial monitoring sheet and timeout tool to optimize antimicrobial prescription. For our actions at Fayoum University Hospitals to follow antimicrobial use and prescription, infection control team with clinical pharmacists review antibiotic prescription to ensure antibiotic policy application by performing the following. Daily clinical pharmacy team follow up the dose optimization treatment of each patient according to clinical state, age, kidney, and hepatic functions. Also review the appropriateness of antimicrobial use after initial order and review change from intravenous to oral antimicrobial therapy in appropriate situations. Follow restriction of some antibiotics according to access watch reserve of WHO criteria, and our team of infection control review targeted therapy based on culture and susceptibility result, monitoring data of susceptibility pattern of a common organism, and also review surgical antibiotic prophylaxis, which is prescribed for 24 hours or not, and it's single use is used or not. Clinical pharmacy team also tracking start day, end day, and end date, and of the use of antibiotic, and measuring antibiotics, which is broad spectrum like carbamine, quinolone, and gentamicin or aminoglycoside. For measure performance evaluations, there are structure and process and indicator and outcome indicators. Regarding process indicators, there are many indicators. Actually, in Fayoum, we stressed on surgical prophylaxis within previous 60 minutes, and we measure surgical prophylaxis if it's stopped within 24 hours after surgery, because we have in some periods we have increase in surgical site infections in some operation like neurosurgery. Also, regarding outcome indicators, we measure antimicrobial consumption by defined daily dose and days of therapy. And regarding antimicrobial resistance or rate of antimicrobial resistance, we have surveillance data. And also, sometimes we measure mortality rate, length of stay, and financial outcome in form of antimicrobial cost. For measuring antimicrobial consumption, actually, usually we use defined daily dose, which in form of total grams of antimicrobial agent used divided by DDD or standard DDD of WHO. Sometimes we use, but not many times, days of therapy, which is the number of days that patient receives the antimicrobial. Actually, continuous monitoring consumption of antibiotic in our data can signal or may signal inappropriate prescription of specific drug. During March, April, and May 2024, our data show improvement of antimicrobial use for third-generation cephalosporin from 60% last year to 45%, and also decreasing quinolone resistance from 58% to 35%. We also measure quality of antimicrobial use by detecting or monitoring empirical and definitive therapy for patients with serious infection. And we have improvement of antibiotic prescription for respiratory conditions, which was major problem in hospitals, because doctors can prescribe antibiotic for viral infection. And this is decreased, thank God, from 60% to 35%, which is antibiotic not recommended for viral infection. Regarding bacterial resistance, thank God we have reduction in 2024 in Clostridium difficile and in multi-drug resistance by follow which our team responsible of daily monitoring antimicrobial resistant pattern and prepare monthly report and use observation check to ensure all infection control procedures is occurred or not, and use infection surveillance form, and this is the infection surveillance form. Surveillance system for resistance data in intensive care units collected electronically by infection control team and antibiogram reassessed annually by microbiological lab. But we have some increase or abuse of beta-lactam antibiotic, and maybe lead to increase in resistance sometimes. Regarding clinical outcome, we measure hospital mortality in form of number of deaths, during hospitalization over time of total number of hospitalization, and also length of stay, which is day of hospitalization by any time of infection over total number of patients with that infection. Improving prescription empirical antimicrobial maybe save infection and save cost and decrease in length of stay. This is okay usually by targeting and restricting unnecessary expensive antibiotic, especially ceftazidime avibactam, which has become used widely in our hospitals, unfortunately. Egyptian drug authorities issue a decision banning circulation of antibiotics, especially all these antibiotics like colistin, linezolid, and tigecycline. Also, we prepare regular reports to antimicrobial on antimicrobial use to the prescribe, and regular reports on resistance to AMS team, and reports for restricted drug, and regular education on antimicrobial prescription provide all clinician and staff. Training of junior doctors, and just some of photos, but we have some limitations sometimes, including essential antibiotics and basic microbiological lab facilities. So we hope to have more information technology resources to be available for monitoring antimicrobial use and auditing the outcome measures. Finally, antimicrobial use data, when it's reviewed regularly with the infection control compliance data and antimicrobial resistant data, this is help in evaluating antimicrobial group program in the hospitals. This is reference. Thank you for your time. Thank you. Thank you.
Well, thank you very much, Dr. Galba, for that excellent overview of the situation in Egypt. Really very interesting to hear. Thank you.
Thank you, Doctor. Thank you.
And we will come back for some more discussion in the Q&A session. But before we do that, we are going to Hong Kong to hear from Professor Margaret Ip. Professor Ip is a professor at the Department of Microbiology at the Chinese University of Hong Kong and honorary consultant at the New Territories East Cluster of Hospitals in Hong Kong. She received her medical training in Southampton in the UK and at the London School of Hygiene and Tropical Medicine. She serves as an advisor and the member of scientific committees on antimicrobial resistance and infection control and expert groups at the World Health Organization. So thank you so much for finding time to join us. We're looking forward to hearing the perspective from Hong Kong. Thanks very much.
Thank you for your introduction and for inviting me to share our stewardship program in Hong Kong. Right. So we also have our action plan according to the WHO to target fight antimicrobial resistance. We are in the second phase of the 5-year plan, which is just recently published for what we have to do. And of course, optimizing the use of antimicrobials in both humans and animals is highly, definitely one of the main objectives. So our medical practice in Hong Kong is the hospital care is under the hospital authority. So it is a bit like the National Health Service in UK, in England, where it is publicly funded. And it looks after about 80 to 90% of hospital bed, or number of beds of hospital beds in Hong Kong. And it also has outpatient clinics, but it doesn't cover for general practice, as a public health care kind of thing. So we are mainly focusing on hospital infections or hospital care. So our hospital authority hospitals are divided into 7 clusters geographically. So we have the Hong Kong West, Hong Kong East, as you see this color coding of the cluster of the hospitals we belong to. So I belong to the New Territories East. And it's under 7 clusters. So within the East Cluster hospitals, we look after 7 hospitals with 2 major microbiology labs. And we have Prince of Wales Hospital, which is the major teaching and tertiary hospital to a certain extent for our cluster. And we have altogether about 5,196 beds. Over 4,000 are acute and convalescent beds, together with other rehab and rehabilitation and for mentally ill. So the whole of the HA, which cover the whole population, or 90% of the hospitalization, looks after 7.5 million of the population, which is the population in Hong Kong. So our stewardship was actually established after SARS-1. We had very badly targeted at that time in 2003. So by 2005, we have quite a bit of a revamp of our public health practice, as well as covering community and hospitals preventative infection preventions. So it is a hospital authority-wide antimicrobial program, which was launched in 2005. So we have been practicing this for close to 20 years. And it was introduced to the major hospitals that have acute admissions, mainly targeting acute admissions requiring new prescription of antibiotics. And at the time, I think one of the major advantage was that a centralized system was sort of established with IT support, so that we are able to centralize the antibiotic capturing, antibiotic use that are captured. We are able to standardize the antibiotic testing for certain common organisms that cause infection, as well as the common antibiotics that are being captured, that are being tested. So the testing method, the abbreviations of use of these antimicrobials, the resistance rate, all these are captured automatically under a IT system that was also established around that time for our electronic patient care systems. So we also have an antibiotic usage database in terms of density, of course, the DDD per 1,000 patient days or bed days, etc. So we are able to call these numbers automatically in our systems. We also, of course, formulated a multidisciplinary team, which is the antimicrobial management team in each of the cluster hospitals that look after their own cluster antibiotic stewardship. And we audit use of the antimicrobials based on guidelines, and of course also conducted educational activities for the individual clusters. We take outcome measure and user feedback to stakeholders, to the hospital level, department level, and also to unit level, so we can communicate with individually ICUs or medical department or surgical departments on their antibiotic use regularly with data supporting. So I think the major advantage was that it was really helped a lot over these last 20 years is the IT support that we're able to benchmark and accumulate the data that are captured also under the headquarters of the infection control branch of the head office. So what does the AMT cover? So usually it is really manned by the medical microbiologists in the microbiology department, but we also have dual role with ID physicians as well as pharmacists and IT support as well as researchers sometimes. And so we also integrate because the medical microbiologists will look after the infection control as well. Integrate the antibiotic usage. The stewardship is under infection control program to do this in parallel. And like other ASP, we have audit feedback system with adherence to guidelines, adherence to indication of use of antibiotics, and we have real-time monitoring of antimicrobial use and the cost, and educational activities for individual programs depending on the cluster. So very similar, I'm not going to repeat this, but certain of some of the aspects we have done, and we have been cycling different programs over time. It has been a long time. So we have now do have restricted use of certain antibiotic, particularly the newer drugs, like the avibactam, ceftazidime, avibactam, etc., or daptomycin. We have standardized antimicrobial order forms at the beginning, but now it is electronic. So it actually is pulled down manual for different antibiotics or certain antibiotics, not all of them, for the indication of use under the electronic pharmacy ordering, the drug ordering system. So the clinician has to click the indication, and we can actually audit this as well when they are being prescribed. We have also used automatic stop orders either at day 3 or day 5 or certain time points for certain departments, so we can cater for individual groups depending on which ward or department we are targeting, and at the time and at the situation or priority. So all these different measures have been used and are used for different parts of the hospital. Now, right at the beginning, we were doing concurrent feedback. It was much more manual at that time. So we actually had a physical team. We have a face-to-face meeting every day with a pharmacist, a nurse, a physician. We also have a microbiologist and engaging different departments. We have the physician, ID person, the surgeon to come and go through the cases with us together. So it was much more labor-intensive work at that time, but we have moved on to using a lot more IT systems, and also at the moment even using AI system to call on or assist in choice of drug. We have various programs like IV to oral switch. We also restrict pharmaceutical promotional activities, and we rely very much on IT support and computer assistance. So, well, to measure adherence and indication for guidelines, we actually have our own Hong Kong antibiotic guideline. It is called the IMPACT. We are currently in the 5th edition, preparing for the next edition because this is a little bit outdated during COVID. But it is available on the app, so you can get it on the App Store or with iOS, Google Play. It is also in a hard copy format, which is available in intranet as well as hard copy on the boards if needed. So we also have antibiogram like most hospitals will have now, which will indicate the common organisms that we grow in the hospital, in the different wards or in ICU, depending on what we need and the range of the susceptibility data for individual antibiotics. And we also have cumulative reporting of the general susceptibility pattern or susceptibility rates to individual antibiotic for certain organisms like Staph aureus or E. coli with these common organisms. And we also have the cost with this data for daily dosing in Hong Kong dollars. And these are all electronic now in the intranet in the hospital. Now, this is the first generation ordering form we have to fill in manually, but it is now electronically integrated into the drug ordering platform. And it is a pop-up form, so it is very good because you can modify and change the practice. You can do a stop order and put out a warning to say, please review your antibiotic, etc. At the moment, we are also integrating an AI algorithm for prescription for certain drug for empiric therapy. Eventually, I think, ideally, we may be able to integrate lab results into a diagnostic stewardship together with an antibiotic stewardship program. So here, the really traditional form is the indication of use that we felt was appropriate at the time. So this has been modified and updated over time. So this is the kind of sort of benchmarking of the DDDs per 1,000 bed occupancy over the years from 2005 up to 2023 or now. So these are all the different hospitals, including the tertiary and all the cluster hospitals in Hong Kong, where we measure antibiotics, and we are able to measure trends of different antibiotics or group of antibiotics, and here with different hospitals as well. So we also have the antimicrobial consumption, DDD over 1,000 bed days occupancy by the individual antibiotic or groups of antibiotic like the narrow spectrum antibiotics or cephalosporins, etc., or group them into the big guns or individual IV oral switch fluoroquinolones, etc. And so we also have these values across the time, and we are able to make comparison quite readily using various baselines that we can use. So, for example, there may be certain drug that has increased significantly, as well as those that have been reduced by 50% or 100% use, depending on which baseline measure we take. And we can do this according to the department level, to the unit level, to the ward level, to the unit level, and total hospital, and comparison of like for like different tertiary hospitals or district general type hospitals. So on top, we also have educational activities, although this vary very much depending on individual hospitals or cluster, with seminars and updates on antibiotic prescribing, newsletters from pharmacy, and microbiology updates. Updates on these resistance pattern or common pathogens, updates on the infectious disease management. We often have to address local issues as well as international issues, because that will also be part of the infection control alert or plans that we have to alert to make the diagnosis and isolate the cases as early right at the at A&E. And we also have to update, together with international guidelines most of the time. So this was one of the review that we did very early on, looking at pre-intervention period and intervention period. Just this was very labor intensive, done by one of the students a long time ago. So just to look at the impact of an interventional ASP on the appropriateness of an antimicrobial prescription, clinical outcomes, and antibiotic consumption and resistance. So it was a prospective study with comparison to a pre-intervention period in the medical department, who were given one of the targeted antibiotic, which was at the time just a list of the big guns that we were using, such as the broader spectrum, piptazole, cefoperazone, sulbactam, carbapenem. So pre-intervention, we captured 605 patients, and intervention 635. We were reviewing it at the AMT group every day, every lunchtime. In fact, in the weekday, but not the weekends and the public health, public holidays. And these were the drugs we were targeting at the time. The cost, they're quite different now. They're a lot cheaper. And at that time, we actually capture a lot of the medical records physically. Now we are also able to call on this electronically if needed. So, I mean, I'm just showing an illustration. This was done a long time ago. So as a whole, we wanted to investigate how much of the drug prescribing was appropriate and inappropriate according to a list of indications. So inappropriate in the pre-intervention was about 20%. Intervention reduced to about 10% or 8% at that time. And the number of reasons for inappropriate, when there are choices of narrow spectrum drug, those bacterial resistant that maybe have to step up or step down, I don't know now. But inappropriate prophylaxis and antimicrobial agent was not indicated. The spectrum was too narrow, side effects from the drug, etc. So we captured a lot of data at that time to understand the characteristics of the prescription. And in fact, for quite a while, we also identified that most of the time, whichever cohort you are looking at, which group of prescription, you have only around 10% that of the drug prescription at most that you can intervene. So how are we able to capitalize on this and make it more effective? And of course, nowadays to utilize a lot more electronic systems to help us. So these have been touched on, I think, in our previous speakers. So what we measured were standardizing and having some benchmark and monitoring the trends of the antimicrobial resistance across the major departments on selected organisms. So we have actually standardized resistance rate across different labs in Hong Kong or hospital lab on MRSA, ESBL, E. coli, Pseudomonas, etc. So that we can know if there is a rise or certain infection control issues that we have to handle. We are able to monitor and benchmark the trends of antimicrobial consumption, again, across different hospitals, across the departments, across the cluster hospitals, etc. as well. We try to audit the use of antimicrobials based on guidelines, which was set out hospital-based as well as from the impact guidelines and the indication of use. We are able to audit compliance use of whether they listen to the recommendation from the teams that make the IV to oral switch or suggestion of doing more investigations, etc. We regularly feedback to the stakeholders at both at head office, to the administration, to hospitals, to departments and unit level, and able to analyze the budget cost. Now, some of these programs are held by pharmacists and some by microbiologists and physicians. So we also have key performance indicators for hospital program, depending who is holding which part of the stewardship program. So I think I won't touch on this list, but essentially what we want to measure is the clinical outcome, the microbiological outcome, the antibiotic consumption, and the finance cost-benefit ratio. We try to make it more effective because we find it is very labor-intensive if you were to look at every case or many cases concurrently at any time. So in summary, our program was started in 2005. We do assessment against certain quality measures. For example, the compliance to define appropriate use, adverse events, diagnosis. Good practice management is still very, very important, whether the cases are well investigated and whether there's drug monitoring, etc. We benchmark and monitor trends on the antibiotic consumption and the resistance rates. And we involve multidisciplinary teams with microbiologists, ID physicians, pharmacists, infection control, and in fact, stakeholders from individual departments like surgery, orthopedics, neurosurgeons, etc. So my suggestion and some limitations maybe is how to streamline our manpower and resources, how to standardize and maximize use of IT and electronic systems. Currently also how we may be able to apply AI tools, how to incorporate diagnostic stewardship into ASP program, how we can also improve our educational program to reach out to every prescriber. With those drugs that need prior approval, not to delay initiating therapy when the patient needs it. And engaging stakeholders are always very important so that it is a bit like infection control. You have the ward, the department, the units to be involved in this practice. But last but not least, I feel that the antimicrobial stewardship together with the rapid ID diagnostic stewardship will even facilitate this even better, that possibly may be able to be integrated in an electronic way or in an AI type of manner, where you have the right test, right patient at the right time, and with the results and the prescription diagnosis to be done with the right interpretation of the results, the right antimicrobial given and at the right time. And together, we need the support of infection control to prevent spread and track and trace. We also hope to be able to track resistant bacteria and identify new emerging resistance. Thank you very much. I will end here.
Well, thank you very much, Dr. A wonderfully comprehensive overview of the Hong Kong situation. So thank you so much.
Okay, so I will stop share.
Thanks very much. Really a great comprehensive overview. Thank you. We have some questions for the panel. We have some from the audience and also some other things to possibly discuss. In the meantime, before we do that, I know that the international team wants to run a quick poll to capture what countries you are all joining us from, because otherwise we don't have that information. So if the international team could put that poll up for people to quickly respond to say where they're joining the webinar from, that would be really useful for us to capture. And in the meantime, if you do have any questions for the panel, please put them in the Q&A box and we will come to them as we go through the questions in there. So carry on putting your questions in the Q&A box. Right, I'm sure you've had a chance to enter the country that you're dialing in from. So I'm going to open the discussion by referring back to a really nice table that Margaret showed near the end of her talk of different outcome measures that one might measure for an antimicrobial stewardship program. And of course, you all touched on that. And we heard a few great examples of measuring the impact on patient outcomes, for example, in cardiac surgical site infections in Canada. But most of the time, we do tend to focus on antibiotic use, be that days of therapy or defined daily doses. Do you think that we pay too much attention to that at the expense of actual patient outcomes and rates of AMR? I'll start with David for that one.
Okay, well, thanks very much, Angharad. And first of all, I just want to say it's very interesting to hear the experiences and practice of people from around the world, because there's obviously a lot of commonality. It may be delivered by different types of people, but the function is very much the same. So I think we're all tackling the same problems, and it's great that the college has brought us together, because I think it's unifying our approaches. I think it will pay dividends. To get to your question, I think we risk missing the point by focusing on antimicrobial use. Now we need to include it, and I mentioned it in my presentation. We do need to look at it, but I think certainly in the UK it can be seen as the be all and end all of stewardship, and that, to my mind, as I say, misses the point. It's all. I mean, if all you want to do is to reduce antibiotic use, then maybe perhaps we just stop prescribing antibiotics for 1 month of the year, and that will get to the point. But that obviously makes it sound, that would be a ridiculous thing to do, obviously, but because patients would suffer. But that raises a question: just by focusing on antibiotic reduction, are we also impacting on patient outcomes in a bad way? And unless we look at that as well, then I think just we are in danger of chasing the wrong target here, which is patient outcome. So I do think we ought to be including that a lot more in national, international discussion. And it's not just about counting the antibiotic use, in my view.
Thanks, David. And Professor Taiwo has asked a question relating to this in the chat, a couple of questions actually, because Silvana, you also mentioned mortality as an outcome measure of AMS programs, but Professor Taiwo is asking for you specifically, how easy and accurate is mortality as an outcome measure of an AMS program when there may be other conditions causing hospital death, and how easy has it been to calculate the attributable mortality?
Yes, Doctor, that's right. It's very difficult to use this a metric to measure or evaluation the antimicrobial stewardship. But we try to detect mortality only for the resistance. And we have in ICUs, especially in ICUs, many patients come after surgery, and they have no infection, but they receive infection in ICUs, and this is lead to deterioration in their cases. And so we measure this case especially. I know we have many different metrics. We try to detect patient outcome as a whole. If patient died, if patient leaves the hospitals, and calculate the ratio. I know it's very difficult, but we try.
Thank you. And Professor Taiwo also wanted to ask whether your IPC team doubles as your AMS team, or do you have separate teams?
Actually, we have a separate IPC team in our hospitals, and lately with manager and head of teams with job descriptions, and we have AMMC. They select one person, head of the team from IPC to include it in AMC.
Okay, thank you. So you have separate teams. So going back to the measurement of outcomes and metrics, going back to Dr. Thirion in Canada, Professor Taiwo is also asking if there's no uniform antibiotic use metrics between your different healthcare facilities, how easily can you compare with other hospitals?
Yes, actually, that's the question is pertaining mostly to the informatics infrastructure that is available. That's the main limiting aspect within our hospital institutions. I think this is a problem that's commonly seen worldwide. But each institution is evolving with their own metrics as they go along, and actually it becomes an extremely difficult point of being able to compare use. Looking at your antibiotic use in your own institution, you don't have a good perspective on what's going on, and you really do need to compare to other institutions. And the thing is that the quality of the data is actually extremely important because there are levels of intensity of care. There's a whole bunch of definitions for patients that are being screened and included in your surgical units. Your medical units are admitting a whole bunch of different types of patients. Actually, in Canada, our reality is that it's a huge country. We have immigrants coming in from Europe on the eastern border. We have immigrants coming from Asia on the western border. We have our native people that are living in northern Canada. It's totally different risk factors for different types of infections. So it's really hard to be able to measure appropriately and benchmark everyone. And that is the main limitation is your a computer system. So you can use basic metrics to be able to compare because that's what everybody is able to get. But then bottom line is you really have to identify your specific targets within your whole healthcare system and be able to get everybody on board to measure the exact same thing. So in Canada, this is done under what's called the Public Health Agency of Canada, and they're identifying our specific targets that we need to measure to be able to benchmark everyone. And we're doing this across nosocomial infections. We're doing it across specific resistance patterns that we want to see, for example, ESBLs or CPOEs. And we're trying also to do it according to specific outcomes on specific disease states, for example, on surgical site infections.
Okay, thanks very much. Great. And you mentioned IT systems there. Margaret, you also mentioned the importance of IT support and the data systems that you have. And another point that might be worth considering is whether electronic patient record systems are adequate for supporting the data needs for antimicrobial stewardship, or do you think that they are able as they stand? Are they useful as they stand for your needs, or do we need to develop them further?
I think it depends on the complexity of how far you want to go. The electronic system is only documented individual clinician who puts whatever down. But of course, there are some standardized format like the ICD coding, prior vaccination, etc. Those are captured. But in terms of comorbidity or some individual like drug treatment, we also call on from the drug formulary, from the drug electronic system, which is much better now than before. So I think, yes, it is possible. I mean, even right at the beginning, we wanted, because the management team had to go through so much data, like on the ward, on every case, to get what we need to make an assessment. So you can just do a checklist of what data you want. It is possible to retrieve just those information if there is someone who is who is able to move this centrally and to make use of this information. But of course, this also very change in time. You may not want to call on certain information or there's too much information. So it does need to be reviewed constantly and how it is going to be done, how to move on, etc. Maybe in future with AI tools, there are much more feasibility or possibility to do this kind of auditing. Yes, it is possible.
Sorry, can I just come in there? Because I during some of the visits, accreditation visits I've been carrying out, I've come across a variety of electronic patient record systems. And one of the complaints I hear frequently from stewardship teams is that the EPR, the electronic patient record system, doesn't really help support the stewardship workflow. And I think there's something missing here in the way that EPR systems are designed, which I think ought to be addressed. I know there's an ISO standard on EPR architecture, electronic patient record architecture. Unfortunately, I've not been able to get hold of the standard because it's very expensive, and can't find anybody who's seen it. It's also from dates from 2011, so it's clearly out of date now. But I think we ought to be pressing as an organisation, as the college and similar organisations, to say that there should be an international standard of how electronic patient records are designed and set up, so that they do support good stewardship practice by making data retrieval and analysis very straightforward. And I think that's just something where we ought to be pushing for maybe joint forces across nations. Thank you.
Well, it sounds like a really valuable suggestion.
I think to make the point, I mean, because our system also changed over time, now we are able to record, temperature charts are all also electronic. So you can actually review the temperature at different time points in the day of every patient. And wound dressings, the wounds, they are all captured on images, also captured electronically. So you can even review the wound infection. I mean, the improvement in the wounds all electronically rather than to go to the patient notes,
Fantastic.
for example.
Yeah.
So
Daniel, you wanted to come in.
Yes, I just want to mention, when we're looking at the data, the issue is not just proper to antimicrobial stewardship. It's an issue for all sciences in healthcare, where they do not have appropriate data to be able to measure what they're doing. And our governments are actually acutely aware of this issue, because they're receiving pressure from all angles of different professions on this specific point, where data management is key to be able to accelerate whatever interventions everybody is doing. This is actually a productivity issue. And we can see it across all our different countries, that whoever has better IT support service is the one that's performing at a faster rate. And strangely, but understandable, is that this is where we're putting the least resources. It's always the IT person that's last on our list. As we can see in our presentations, we're putting them last, but we're not prioritizing our resources to be able to manage those. And so I totally agree. We need to centralize our requests with all other organizations, that the IT support has to be improved throughout our healthcare system.
Great point. Thank you. David, there's a question here specifically for you, asking what assistance can BSAC provide for AMS programs in health facilities in low and middle income countries to work towards GAMSAS accreditation?
Okay, well, thanks very much. So first of all, have a look at the BSAC website and go to the accreditation page, because that will provide a background to the GAMSAS program. If an organization thinks it's already at a stage where it might want to apply for accreditation, there's a screening questionnaire which starts the whole process going. For organizations that aren't sure whether they've set up an adequate stewardship program yet, or know that they haven't but want support, then go back to the BSAC website, look at educational material. There's lots of free, openly available resources on antimicrobial stewardship, ranging from an ebook that's freely downloadable, or webinars that last for an hour or so, to massive open online courses that go for 6 weeks or more. And these are all freely available. The other thing to look at is the GASP-H page. So this is a Global Antimicrobial Stewardship Program hub. And that's a curation of lots of stewardship resources, including papers, guidance, or webinars, and so on. So there's a lot out there which is freely available. That's a starting point. Once you've had a look at all that and try to work out where you are, as I say, make contact with BSAC. One of the questions we get asked a lot is, how much does it cost? And I have to say, we run a kind of Robin Hood method, which is we steal from the rich to give to the poor. So we charge more for high-income countries versus low middle-income countries. And we try and reduce those costs as much as possible, usually by bundling up inspections so that we can deliver several visits within a limited geographical area to minimize travel costs and so on. But, get in touch with BSAC if none of that answers your question. Just drop us an email to the GAMSAS website, to the GAMSAS email box, and we'll get back to you with very specific information, answer your questions. So thanks for that question.
Thank you. Some great signposting there that I'm sure people find useful. Thank you. We have a question for Silvana about the Egyptian presentation. The question is, what kind of KPIs were used for programs in Egypt?
Actually, the most important KPIs we are used is measuring rate of resistance, antibiotic resistance. It's number one and number 1,000. And also measuring consumption of antibiotics. They are two metrics are used usually for many or all hospitals actually. Sometimes the prescription of antibiotics and if the measuring detection policy, accurate policy or not, may be measured, but first one rate of resistance and second one antimicrobial consumption rate.
Great, thank you very much for clarifying that. So I'm moving down the question list. I have another question for David Jenkins. Oh, but I think we could put this to everyone. Recommendations on how to approach senior leaders and get them and persuade them really to buy into AMS education trust-wide for all staff. So we'll start with David, but we'll go to everyone with this one. Your tips for getting senior leaders to buy into AMS.
So I think you have to find out what they know about antimicrobial resistance and antimicrobial stewardship. For many clinicians, it's a fairly new or unknown concept. So understand what they understand and set out to educate using both data to demonstrate the issue locally, but also nationally, internationally. Particularly focus on antimicrobial resistance, the impact of resistance on the ability to treat patients. If you can find patients of theirs in particular who've done badly because of resistant infections caused by resistant organisms, it's well worth highlighting those. Point out that it's not just about their prescribing, it's about prescribing across the organization. Highlight how much antibiotics they use, get them to understand how antibiotics really underpin their clinical practice. For example, virtually all surgery these days, certainly in hospitals, utilizes antibiotic prophylaxis. Point out how if antibiotic prophylaxis isn't available because of widespread resistance, go back to what the situation was like before antibiotics. And there's a great quote from a previous president of the Royal College of Surgeons, I think it's from about 1921, where he said every operation in surgery is an experiment in bacteriology. And the point he was making there was, infection is such a common occurrence, particularly for abdominal surgery, that it's an inevitable occurrence. Now we're nowhere near that now, but that's only because we've got effective antibiotics. So making the point about the importance of antibiotics to sustaining, whether it's surgery, cancer, intensive care, transplant, all that sort of stuff, we just highlight the central importance of antibiotics to modern day clinical practice is one thing. Second thing then is talk about resistance and demonstrate local resistance patterns. And of course, that will vary around the world. But the important thing to point out is, and this is generally true, is resistance is generally increasing. And then the third element of this is to highlight the shortage of antibiotics in terms of the development pipeline. And also, those antibiotics that we have had recently are extremely expensive. So, for example, 2 new cephalosporins in the UK, 2 presentations of cephalosporins, cefidericol and ceftazine avibactam. Within the UK, the unsubsidized cost of cefidericol is around about £950 per day. And I think for ceftazine-mavibactam, it's £300 or £400. Now, we do have a subsidy system in England, so we don't pay that much. But even so, we're still looking around about a couple of £100 to £500 a day for treatment. And that means that no healthcare system on earth can afford widespread use of those antibiotics. So we really do need to preserve what we have. And stewardship, again, demonstrate that stewardship can work. It's not just about counting antibiotics, actually preventing resistance and improving patient outcome. And again, focus on it's about patient outcome. It's not stopping antibiotics for the sake of stopping antibiotics. It's about improving the response, the care that our patients get. I'll stop there. Thanks.
Thank you. Lots of good persuasive strategies there. Margaret, how have you got any tips on approaching your senior leaders to get them to buy into providing education on AMS trust-wide?
Well, I think back in 2005, it is very, very hard. You go to every department head, everyone to engage them. And even that, you get a lot of feedback. You cannot reach the antibiotic early enough. You can't stop this antibiotic. You can't do this. You can't change the antibiotic just like that. That's why I think that diagnostic is very, very important to support. And of course, still a great proportion of the diagnosis, we don't have a culture result or the pathogen, and that's very challenging at times, particularly very sick patients or with underlying chemotherapy, malignancy, or on chemotherapy, etc. So it's a challenge, but you have to push forward. I think if you have to achieve and agree, and it can also be top down to the other departments and the individual prescribers. So you need to engage them basically. So we, at the beginning and even now in certain circumstances, you go to individual department to arrange to talk to them, to go through the report, to go through the audit, to look at certain group of issue, like certain antibiotic or whatever. So yes, it does take a lot, but you have to provide the data to support why you want to go and see them for a particular reason, how to engage them.
Thank you. The data, yes, and thanks. And Daniel.
I just want to add, I use the same techniques as I do for behavioral change with my physicians. Actually, I just benchmark them. So I use other systems, other countries, and show them what performance they're doing in antimicrobial stewardship, and mention how our hospital is performing according to that. And we have dismal, well, compared to other income countries, high income countries, we're not having good IT support, and they understand that. So it convinced them pretty quickly.
Okay, thank you. Another good approach. And Silvana, do you have anything to add on this point? Can you hear us?
Yes, actually, we're facing a big problem about changing cultures, about prescribe of antibiotics, especially in surgical prophylaxis. Doctors may give one or two drugs during anesthesia, and may also give antibiotic for a long time after operations. We try to change the concept of this, and sometimes we face a large amount of increasing in rate of surgical site infections. We try to train, give feedback and audit about surgical prophylaxis in our hospital. This is a main problem.
Okay, thank you. Great, a really stimulating discussion there. We've just got time for another couple of questions before we reach our allotted maximum time of 2 hours. I think the next question that we have touches on quite similar themes of encouraging colleagues to provide a high standard service. So I think that perhaps some of the points will be quite similar there. So I'm going to move down to a question about establishing strong and sustainable collaborations between AMS programs in human and veterinary medicine. who's had experience working on One Health programs or in working with veterinary medicine. Shall we start with Canada and Daniel?
Yes, actually, it's a challenge that we've been facing for a number of years. And what we set up here in Canada is that we going again through our government to have a One Health approach, and to have, because we have over 100 different interest groups on antimicrobial use are coming from all over the place, but we have to get them centralized and organized to allocate the resources appropriately. And so we're doing it through our central government, where we're implicating veterinary expertise with our infectious disease expertise on managing the spectrum of antimicrobial contamination resistance throughout the whole food chain, and appropriately using certain antibiotics in our veterinary care use according to what we're using in our human care. So all of this has to be centralized through our government, and that's actually the best way of doing it, because we've seen that everyone's really focused on their own little aspect of work, and they don't have time to go into other spheres or fields. And you really have to have a multidisciplinary team that's focused on the overall big picture.
Okay, thank you. And Margaret, how is this in Hong Kong?
Well, good thing is we don't have many farms. So, but we do have. So in the committee, there is a representative from the agricultural government side with a representative, and there's also a veterinarian who's representative. But I mean, for the vets, there are also very few, relatively. But they are like a private, general practitioner kind of equivalent. So it is. I mean, we are also looking at community use of antibiotics and community use among veterinarians and in farms. So there are different programs to look at that, because a good proportion of these are private. They can be very difficult to approach and to obtain the information that you need. But yes, I think it would be a combination of educational tools and a lot of, I don't know, enforcement. I'm not sure, but it's being conducted currently or investigated currently.
Thank you. And Silvana, what's your experience around this in Egypt?
I think for hospitals of Ministry of Health, there is a committee. I think it's developed 3 or 5 years ago to combat antibiotic resistance among animals, and try to communicate with the antibiograms in hospitals. Also, regarding university hospitals, we start to communicate with other doctors for more and more lectures, more and more conference, more and more sometimes workshop about decreasing use of antibiotics for plants, for environment, for animals, which become a huge problem and make a resistance in our communities in large, increasing in large amounts. So we try to communicate.
Thank you very much. And I'll go to David next. And I will also ask David whether when he's discussed a little bit about the One Health question that we have there, whether you could also go on to the specific question underneath from Dr. Ferriter, who's working as a GP in the UK as well. Thank you.
Sure, thanks. Well, it's true that at a kind of hospital level, we don't really talk to vets at all in this country, and the One Health program is very much a high level program at government level. However, there are things that individuals that the public should be doing here, which is, their potential exposure to antibiotics through treatment from their GPs or from their hospitals, but also from the issue of antibiotics in food is something which is they should be very interested in. We should all be very interested in, and it's interesting to see how the purchasers of of farm products, so the big supermarkets, particularly in this country, have been driven by public interest in antibiotics in their food and antimicrobial resistant organisms. And those big purchasing powers that the big supermarkets have been very effective at driving down antimicrobial use within UK farms. And I think that's something that's worth noting. And I'll leave it at that point there, I think, because I think we've covered it otherwise. Going to the next question then, which is about antibiograms and having access to those if you're a prescriber, whether in a hospital or in primary care. That is something which your local microbiology laboratory should be able to provide for you if they're not already providing it routinely. So, for example, if you're a general practitioner, then your local laboratory should be able to provide you with at least an overview of the types of organisms identified in urine specimens and their susceptibility to antibiotics. Now, there is a little bit of caveat here, at least in the UK, because for many years, microbiologists have been desperately trying to dissuade GPs from sending in urine specimens. And so the urine specimens we do get in are often from patients who failed on antibiotic treatment or have got specific issues. So we may overemphasize resistance with those antibiograms, but that again, that's something which we ought to be looking at and maybe getting some kind of general samples coming in from occasional, perhaps GPs send in the first urine of the month or the first urine of the week, whether it's a simple one or not, so that we get a much better understanding of what's really going around. But basic answer is speak to your microbiology lab and see what they can provide you.
Great. Thank you very much, David. And with that, we've come to the end of the questions from the audience, and also that's pretty much perfect timing for our 2-hour deadline. Thank you all so much for a brilliant discussion, which I found very enjoyable and informative. I'm sure the audience did as well. Thank you all very, very much for joining us. Now, I'm just going to wrap up with a few final slides. So let me find those. So this is to remind me to point out that this was the last webinar of our 6-part Global Antimicrobial Resistance webinar series. But all the webinars from this series have been recorded and stored on our website. They take a week or two to arrive on the website after the time of the webinar, but they will all be there within the next 2 weeks. You might also be interested in the Royal College of Pathologists' International Pathology Day event this year, which will be on Wednesday, the 6th of November. And we will have a theme at that event of the rise of global antimicrobial resistance. So you could register for this on the college website. You'll be able to find the link on the RC Path website on our conference pages. We will send round a short feedback form after this webinar, and we would really appreciate it if you could just take less than 2 minutes to fill in this completely anonymous feedback form. So there we are. It remains for me to again thank very much Dr. David Jenkins, Dr. Daniel Thirian, Dr. Silvana Garber and Professor Margaret Ip for their presentations and providing such brilliant insights into your respective countries. And also a huge thanks to Giles Hanratty of RC Path International team, who has worked tirelessly on this series for months behind the scenes, and without whom we would have no series. So thank you very much, Giles. Thank you to everyone who attended the webinar as well, all of the audience. I hope you've enjoyed it. I hope you've enjoyed the whole series and found it useful. Goodbye, everyone, and have a great weekend.
Goodbye. Goodbye.